Good afternoon. We are going to be bringing a webinar to you that I think we first debuted at the Wellbeing at Work events that we did in London and Manchester, and
Right.
that would have been last September, maybe. So this is the first time that we've brought this to sort of a virtual audience, and it's a topic that I think has got a lot of interest in. One that I think we're both have some good perspectives on, and hopefully the audience will get a lot of value from today. So we'll have a look at what we're going to discuss in the agenda, but before we do that, we'll do a bit of an introduction on both sides, and perhaps Andres, you can start with yourself.
Yeah, no, I'm one of the founders at Thrive. I'm a consultant psychiatrist by background. Yeah, delighted to be here. This is a topic that is very important to me, and hopefully we'll get a good discussion, and you'll find it valuable.
Fantastic. And I'm the co-host, I guess, for today, and co-founder of the Thrive customer success team. So customers that we've got on the call today, ultimately responsible for you and making sure you get the most value out of our service, supporting you, your employees. Very passionate about this subject matter, and also a little bit of a plug for any existing customers that are on the webinar. We're holding a virtual event would be next Tuesday, where we're bringing together our customers. We have a customer community event, and we're going to be talking about some of the sort of service enhancements and what we're going to be doing from a product perspective this year. So a bit of a plug, check your emails. You should all be invited for existing customers, but we'll bring ourselves back to the topic that you've come here to understand and listen to today. So in terms of what we're going to be going through, you can see some of the areas that we're looking to explore today. And when Andres and I were speaking earlier, some of the things we touched on, Andres, is that, you know, we've made some real strides in respect of addressing some of the stigma that is associated with mental health and people coming forward. But actually, we're seeing more people coming into services. We're seeing more people coming into therapy. And whilst that might be a good thing for some people, there is potentially a bit of a tension on the other side. And we want to explore a little bit more about therapy, what it's really for, what the objectives of it are from the individual's perspective, but also some of the considerations that you can think of or be mindful of, rather, as someone going into therapy, but also from a clinician's perspective and then from a service provider's perspective, some of the things you need to be mindful of and consider also to keep your therapist, I guess, accountable and to make sure you're getting the most out of that dynamic that is between you and the therapist. I don't know if you want to expand on any of that, Andres, but we're going to tuck into some of these themes as we go into the webinar.
Yeah, that's right. I think we'll you know, as it says there, we'll introduce the idea and, you know, a little bit of like what is the cultural moment now and maybe why we're seeing some of the things that we're seeing, and then just explaining, as you said, the facts and outcomes around therapy and why we say that it can be a crutch or it can be a catalyst. So and how to tell those two situations apart, I think is the most important thing. Yeah.
Fantastic. I've got one comment about potentially some echo on my sound. Whilst I'm a bit of a risk taker, I have got another microphone, but I don't fancy unplugging it mid-session. So I'm sorry if there's a bit of echo from this room, but hopefully you can hear me and it's not too distracting. So we'll carry on. If you can bear with my sound of the sound dynamic. So yeah, let's explore this, Andres. So as we've said, there's more people seeking treatment. There's more noise around mental health generally. You know, there's many good things which come with that. However, there are some of the considerations when we think about therapy, which has entered the sort of popular discourse, if you like, now.
Yeah, I think you know, when you try to reduce stigma is very good. You know, it's important to do so. I think it's been quite successful in some ways, although some specific mental health conditions continue to have, well, a lot of stigma around them, but many of them have been, to a good extent, destigmatized. And I think we've seen that people are able to sort of seek help more readily, which is good. So that in itself is good. But there's a flip side to it, and we see that some of the things that some of the terms, some of the terminology, some of the very specific contexts that make sense in a clinical setting are adopted into mainstream culture. And you know, there's terms, I think I collected a few because there was that study that I'm highlighting there. So, you know, mental health clips being quite a popular, for some reason, category. And then, you know, terms like gaslighting has a it doesn't come necessarily from a clinical setting, but it does have a meaning in the context of treatment where there's like intense psychological abuse. So sometimes it's used to refer to just simple, like somebody lying to somebody else, and you know, just gaslighting. Or I've heard people say things like, I've got social anxiety, when what's happening is that they're just shy. So there's a difference between those things, but there's an adoption of those clinical terms, and I think it's fine. But in some cases, I think it leads to increased frailty, because you are seeking this. You know, again, it's the flip side of that decreasing stigma, right? Am I okay? Am I okay? Am I okay? I should look for solutions when I have a problem, and then you look too intensely for those problems, and because you're not very clear on what these clinical terms mean and where the thresholds are, you might think that you experience some discomfort. You may be a bit distressed, but you probably are not crossing that clinical threshold. Yet you use these terms to describe how things are. There's other incentives there that may actually even increase this effect. Like we see there's the neurodiversity, again, very good in terms of like there's people with actual neurodevelopmental conditions that do struggle quite a lot. But again, you know, there are you know, you can identify into some of these categories. And yes, you will have traits of, you know, if you read the description, you will have traits. And you may end up, even if you pay for it, with a diagnosis. I'll say something about the incentives there and how that might happen. But you might detect extra frailty in you that is not there, and is more about, you know, let's say that you have those traits. It's more about learning how to cope with them and how to adapt to situations yourself, because that empowers you to be more, you know, to be able to engage in more things. Ultimately, it is an empowering thing. So that's what I will say about that cultural moment. And my concern is about some of these losing their meaning and being adopted, as I say, there as lifestyle adjectives is what I would say.
Got you.
Again, not across the board, but in some cases, I think it's important to note that. Yeah.
Yeah. So if I can summarize, at least from my read, so there's a lot of effort and good intention and progress in destigmatizing the subject of mental health. We've got more people accessing therapy, which can be a good thing. Yeah. But you've got the potential danger of over medicalizing in some of the language, which can, for some people, lead to that kind of a potential of being more frail, because, you know, I am this without that necessarily actually being that thing.
Yeah, I mean, nobody's denying that there's some distress, but it might not require a clinical intervention. I suppose is what I'm saying. The other you know, downstream effect of that is that, you know, people who actually struggle quite a lot and function poorly may have reduced access, because they get crowded by other people that perhaps are in this, you know, again, nobody's saying that there's no distress. There is, but that the needs perhaps could be met in other ways rather than, you know, through a clinical intervention. I suppose that's the distinction there. Yeah.
Got you.
So I mean, I think this is another point. This is part of the argument, I suppose, is where we see that there's an increase in the use, in the access to therapy, but we don't see an improvement in some of the key outcomes that you expect to gain from therapy. So that's kind of the contrast there. So yeah, many more people accessing these services, but many people, for whatever reason, not getting good outcomes, or we're not seeing a reduction in some of these indicators, global indicators of mental health. I think that is part of the argument, part of the things to sort of bear in mind.
Yeah, 100%. And the organizations that we work with obviously want to do something about what sits on the right hand side of the screen, as we all do, who work in this area and as human beings, right? But as we'll come to explore, there can be some things that may sort of hamper those individuals actually reaching a recovery, and some of the considerations and potential drawbacks of certain types of relationship that are kind of this ongoing chat style nature of interaction, which can be cathartic, but may not get the outcome that is beneficial for you.
Yeah, I mean, again, we see a similar pattern in the US, like we were saying before. Increased claims. There's increased claims in the UK as well, by the way, in primary medical insurance for these types of conditions. Yet again, we don't see an improvement in ultimate outcomes, or the outcomes that we're really concerned about. So again, more therapy doesn't guarantee. So nobody's saying that therapy is bad or it doesn't work. I'm not saying that. I'm saying is the right application of therapy for the person that actually requires it is the thing that we need to strive for. And again, to try and, yes, there's more demand. That can be fine. That's not a problem. But it's about identifying those people that can definitely benefit from a clinical intervention, and also that when the clinical intervention occurs, it is delivered in a way that is conducive to recovery. That's kind of the key takeaway. So more therapy does not guarantee better population outcomes. Kind of the takeaway message for now. Let's build the argument.
So this is the first juncture, I guess, to engage and participate. So I think this is a question that's a good one, and maybe some of you have on your mind. So the Slido poll gives you the ability to participate. All you have to do is scan the QR code that you can see on your screens. Or if you'd like to do it the alternative way, it's slido.com, and then you put the hashtag 4203000. So yeah, let's get some of your perspectives on when is that right time as an individual. When do I seek therapy? What's the appropriate juncture to do that? No wrong answers.
Yeah, no wrong answers. Absolutely not.
When it feels overwhelming is the first initial thought, which is a very logical one from my perspective.
Definitely. Yeah, it's a few people typing, so I feel like I go preventative. Okay.
We might hang on to that one actually and explore that in a
yeah, we will. Yeah, I think so.
Detail.
When my usual coping strategies are becoming ineffective, like that. Want to change the outcome after consulting with a GP. There you go.
Referrals.
When I notice emotions are far too high, when the GP recommends.
Yeah, there's sort of building on another one where, when I've tried my own coping mechanisms,
can see a potential issue. I'll leave it until a crisis. Yeah. I suppose that the preventative might be along those lines. It's like you see a potential issue coming.
Impacting on
all aspects of life.
Yeah. So we'll probably talk a bit about sort of the distress and dysfunction, which you speak about. But some really good thoughts there, and some common themes grouped within the different responses.
Yeah, I mean, I think I like the one when you feel that you need help. So again, I don't think there's a wrong answer here. I don't think this is on the side of the individual. So I didn't want to come across in the previous few slides that we are discouraging people, or I'm saying that some people feel like things are overwhelming, but they shouldn't be looking for help. That's not at all the message. It's actually quite the opposite. you do need to do it. So, if you think things are not working, things are difficult, things are challenging, definitely one should seek support and help. The one thing that I would say is that it is very much on the part of the clinician. And if you're a user of these services, I think you need to understand this dynamic. So there is a difference between a clinical threshold and not a clinical threshold. Why is that important? Because I know that when a clinical threshold is crossed, I can help. When it's under that, I might not be all that helpful. So it is, when you're distressed, it may not be the thing that you want to hear when you go and see somebody that actually we shouldn't be doing this because it might be actually counterproductive. You should seek help. You should have that consultation. You should have that discussion. But there might be that answer that comes your way, that actually there's other ways to deal with this that are probably more productive, rather than actually going down the route of an actual clinical intervention. I suppose that's the thing. So it's never on the part of you to decide whether you can seek help or not. If you feel that you need to seek help, I think when I feel I need it, I think it's a good answer. Definitely. But it's more about understanding that there is a discussion, that there is an assessment that takes place, and if you are in front of a good clinician, the clinician should be able to guide you to what the best intervention is, and it might not be what you expect if it's a good clinician. That's kind of the takeaway message there. Yeah. So Rich was talking about distress and dysfunction. Those are very good indicators. So there's three main indicators that a clinician would look at when deciding whether a clinical intervention is worthwhile doing, or is important to do, which is how much distress there's is experienced. And obviously you will, because you're seeking help, you will experience a certain level of distress. But again, a good clinician, experienced clinician, will be able to tell where the threshold is. So that can vary. So when there's distress, when there's dysfunction means that you're not able to sort of fulfill your day-to-day activities in the way that you normally do. Maybe it is work, maybe it is just functioning at home, maybe there's other forms. And particularly when it's more than one domain, it's when you're more worried about it, and when there's risk. So is there any risk that is happening here? That is also a strong indicator for intervention. Just so that you're clear about how somebody like me might think about a situation.
Got you. Thank you, Andres. Let's move on, if we can get past that one. So yeah, Crutch.
Yes. So I mean, the point here is that you do need to establish this early safety or safe place to have these discussions, and to enable rapport to form, and to enable trust to develop. That's definitely the case. So that's important. However, it can become, or an indicator that it might be becoming something that is less helpful, is when you're thinking about running everyday decisions via the therapy. So when you feel, when you are substituting your own judgment for, oh, I need to consult this, when you're not working towards getting stronger in some way, growing yourself, being more empowered, more capable, that's when I would worry about whether this is going in the right direction. If you feel that you're going to constantly, if it comes a time when you don't feel that you could function without having those consultations, that to me indicates that things are not going to be helpful. And there's actually this, I've got it there, this care dependency questionnaire. It's a tool that is developed because this is as you can imagine, is not something that I came up with. This is a common problem in when you're trying to sort of deliver a service and deliver therapy. This questionnaire, the result of that questionnaire can predict whether somebody will not have a productive time in therapy. So, and it's a good, useful tool as a therapist to be using to monitor whether that we remain productive. This is conducive to growth and recovery, or whether we've stalled and we need to do something else to make sure that we continue to progress. That's where that comes from, just so you understand it. So, and there's differentiating that that support that needs to happen versus creating an excessively comfortable environment that doesn't conduce to growth and development and recovery. Yeah.
I think we'll come on to cover this in subsequent slides, but would you say it's, I don't know if you can you can say on this, but is there any kind of common practice to defining at the real outset of the relationship when you're working with a new therapist as to, you know, these are the expectations of what is with you, what is with me? Is that common practice to kind of define that responsibility, the expectation, so that individuals realize maybe early on that, you know, hey, I'm not here to solve all the problems.
No.
You are going to be the one doing the
Solving
work.
the problems. Yes.
But I'm here, I'm creating that safe space to have that discussion.
Yeah.
Do you think that's a commonplace practice across the industry, or is that more dependent?
That is good practice. So that is actually, yeah, if you look at specifically that would be good practice. What you would consider good practice is being able to sort of very early on, like, outline what the purpose of it is, what very clear, I mean, we'll talk about it in a minute, but what the goals are specifically and how we're going to get to them. One of the things that may be quite challenging, and we'll see why it can be quite challenging, is actually telling somebody that a lot of most of the effort, being honest, is placed on the person receiving the therapy, not on the therapist. So the therapist, by me talking to you, I'm not going to make anything better. That's not how it works. It's not like I have magic words that will conjure wellness out of you. You might feel good in the interaction, in the conversation. It might be a nice conversation. It might be, you might feel that this is cathartic, or that you're gaining good insights, as we'll see in a minute. But it doesn't necessarily mean that you're going to improve or get better. You might be stuck in that cycle. So yeah, very important to say, some of the things that we're going to do here are going to be very effortful, and you're not going to like them, and it's really going to suck. But that's the way we sort of progress. But actually describing that very early on, in my experience, has always been very useful to frame it well, and to understand that the point of this is not for us to have a chat. The point is for you to not need to have any chats with me ever again in the best possible world, because you've got the skills now to cope with these situations that are maybe quite difficult on your own. So again, nobody's saying that the situations are not difficult, but it's more about equipping yourself, developing yourself, growing your skills and your problem-solving abilities, so that you're not needing this support from somebody like me. Yeah.
So let's explore that.
Yeah, and this is what I suppose what I was touching on, right? So RCTs where there's an unsupportive randomized control trials. So these are clinical trials exploring some of these questions, right? So if it's an unstructured chat, any outcome that you care to name, any long-term outcome that you care to name, remains unchanged. This is the loneliness study, right? So things didn't change, and this was an unstructured supportive chat. That was the intervention, right? Now, if you ask individuals participating in that trial about the individual sessions, they loved them. It was great, but it didn't end up with any good points. And the flip side of that, what I was saying before, is because you're in this environment where everybody, like TikTok, everybody's got a mental health condition and all of this, over medicalizing ordinary stress may get you into the situation where you gain insight about how you're feeling, or these things, and you might feel very nice, but we know for a fact that doesn't lead to long-term benefit. Yeah, again, may feel very nice in the moment, and I'm not denying that if you're in therapy and you do gain some understanding and some insights, that's going to be helpful, but only in order to realize that you have to do the hard work and the practice to acquire those skills. This is the reason it's important that we invest this effort into the recovery.
Yeah, we've had a question which I do want to pick up, and because I think it's a great one, and one we actually explored in preparing for this. It's around Do you find certain types of therapy, i.e. talking therapy, may develop more of a crutch? So we're talking about different modalities that may lend themselves to this, which is something that we sort of picked on earlier.
No, I mean, I think we do comment on it later. There's certain modalities that are more inducive that we know from the evidence that result in better outcomes than others, and it is those structured therapies that actually do seem to show the benefit and long-term outcomes. And actually, interestingly, those are the ones when you actually do complete them and internalize the skills on follow-up year on year, those are the ones that seem to have sustained benefits rather than short-term feeling a little bit better. If that makes sense, if the difference between those two things makes sense. So if I follow you up like a week after you completed your course of therapy, you might be feeling it, I'm good, right? But if I follow you up 6 months later and you have one of those unstructured forms, you gain nothing from it, and you might be back where you were at the beginning. Whereas if you complete the very effortful, difficult, and sometimes very challenging, more structured forms of therapy, and you work hard, 6 months later, 1 year later, 2 years later, you've gained the skills, you know how to use it, you know how to deploy them, you're better. Yeah. So this is just about explaining what happens on the therapy side. Yeah. So there's certain incentives that occur. So the transference is like what you feel as the client, right? So you feel nice because we're having a good chat. There's a hit of validation. I'm very complimentary to you. I listen to you and all of that, and that sort of seems to you feel better for it. And that's, for example, we've seen that in some of the articles published on AI chatbots that do this. They are not they've never been programmed to do therapy. They've been programmed to be nice to you, and to keep you engaged, and to be as validating and as flattering as possible. And a lot of people love it. So if they do have the knowledge, so it's interesting because they sound very believable. So they do have the knowledge. So you may start, and we see this in studies. You may start at very supportive, with a very clinical tone of voice in those chats, and then it drifts into friendship. Interestingly, that can also happen in actual therapy with actual human therapists. That same drift may happen. And again, that validation feels nice. And I, as your therapist, want to keep you engaged because various things. It just feels nice because I have a good session with you. But I also, in the back of my mind, again, I'm not saying that you're doing this on purpose or anything like that, but that incentive exists. That if I give you one more session, I earn money from that one more session. So again, not that I'm doing this on purpose. I can rationalize this and I can say, yeah, man, one more session might be good. You feel nice, I feel nice. If I don't challenge you too much, then the chat is nice. That countertransference, so is how I feel about the situation, feels nice as well. So we're all very cozy and not really making a lot of progress. So without goal is what I have there, therapy drifts. And then if you don't have clear goals by session 3, you may not get there, is what we know from studies. Yeah. This is from an audit internally in the NHS a couple of years ago. Yeah.
Okay.
Yeah.
So we'll open up some of these things that might contribute to that kind of stagnation.
That's right. Yeah. So these are the contributors. These are the factors that can land us in those situations that we don't want to be in, and they can happen. It's from both sides, right? And again, I never blame the client. The client doesn't know. It is that sometimes some therapists should know better. I am making that statement, even though it might get me in trouble. But yeah, so session volume equals income. I don't think anyone can deny that. And you can be the most ethical practitioner in the world, but there is an incentive, and incentives have a way of doing things to us humans. So you need to be very, very well aware of your incentives. So you may be worried about your income in the very, very back of your head, but also having a conversation about stopping therapy is hard. It's hard.
Mm.
Unless you've had that very early chat in which you framed it well and you keep preparing somebody to do that, it might be very difficult because you start off very nicely. You do have to form that, what we said at the beginning, that early safe space, scaffolding for what this is going to be, develop that rapport and trust. And this might like rub against it or be at loggerheads with it, so they have to do those two things. So you have to be quite skilled and experienced to actually manage both things, to do both things at the same time. And why do I say the danger of testimonials? Because again, if I'm very nice to you and you have very nice and cozy conversations with me, and you feel that you're gaining those insights, you may give me 5 stars. But if I'm a little bit challenging and I want you to work hard and I insist on homework and I insist on goals and I insist on are we making progress or not? Is this being helpful or not? I may get 1 star. You may say, oh, this therapist is rubbish. I stopped because I wasn't getting what I wanted. 1 star. So the testimonials might not give you the full picture or might give you a skewed picture. That's what I'm trying to say. So don't, in this arena, they may not be very reliable. If you can have outcome data, that's what you want.
Mm. Yeah, and I think we're so used to, though, to your point there about testimonials, whether you're looking for the restaurant or whatever, it's kind of, okay, is that my initial benchmark? They seem okay.
Yeah, but I mean, so it's very different. So a restaurant has a very different mission from a therapist.
Yeah.
Or a doctor. So you come to me and you say, I want painkillers. Am I going to prescribe painkillers for you? Probably not. Are you going to like it? No.
Mm.
Unless you really, really need them, and it's for a short time and all the rest of it. But I might have to say no to things that you want because it's not in your best interest. So and again, you're not the one who is to blame for asking for it. Let's say, give that example. Let's ask for the painkillers. You're not the one to blame for asking for painkillers. You're in pain, but I'm the one to blame if I say yes.
Yeah.
Yeah.
So perhaps if you're I don't know, someone responsible for procuring a service to support your employees, then you're looking for things like those service outcomes. What's happening to the people that are in this service, how they're getting better, how they're improving, rather than necessarily.
Yeah, and there must, for example, there's a tool, the Core 10. It's a tool that looks at outcomes from therapy, but it's very deliberate about how it's done. So, for example, there is a testimonial component to that. There is a goal attainment component. You say how much your goal was attained. What did you find helpful about therapy? What didn't you find helpful about therapy? What was challenging? Are there any things left to work on after you finish this episode of therapy? And then there's a question at the end: is would you recommend this to somebody else? But it is done in a very deliberate way at the end of therapy.
Yeah.
I went to see this chap a couple of times. I didn't like it. 1 star. You see what I mean? There's a slight difference between those two scenarios. Yeah.
Okay.
Yeah. So what is the boundary drift? Again, it's another indicator that things might not be working well. So excessive self-disclosure from the point of the view of the therapist. Again, that drifts your role, that drifts your boundaries. It is important that you remain in this therapeutic stance for you to be effective and to be able to engender this or motivate this change. So when it drifts into like a companionship, strange companionship, but I'm your provider as well, and you're my client. That's where the frame can drift, and we can end up with these paid companionship scenarios, which again are not conducive. They might feel very nice, but are not conducive to long-term improvements. So that's why all ethical codes that you care to name in therapy always insist in these boundaries to maintain that stance, not because of anything, but mostly to protect the client from wasting their time at best and being exploited at worst. Yeah.
And is that something that supervision from a perspective of the therapist can help
That's why supervision is so important. Yes.
Right.
And not only that, so it's got two components. One is supervision to enable, so when I do a lot of supervision, a lot of clinical supervision. So one of the key questions is how many clients you're working with. Are you what are you, which ones do you have questions about? Do we need a case discussion on any of them? Particularly the ones that get stuck. Those are the ones to really, pinpoint and look at, because there might be some drift. And you as the therapist might not even have detected it. And you do need that perspective from your supervisor to be able to negotiate it. And then when that happens, which can happen, is about how do you then tackle it with the individual so that you can get the thing back on track, whether it's possible or not. Sometimes you do lose that therapeutic stance and that therapeutic relationship, and you have to be very honest with your client. I'm not really helping you anymore because he's drifted. Yeah. So, and again, that's the supervisor's role to ensure that that drift doesn't happen, or if it does happen, to be very, very honest with the client, with the person attending therapy. Yeah. So again, I think this was your question. You do flag discharge like day one, definitely, and then you could do this boosted check-ins. I am kind of in two minds about them. Some people do them, and they can be quite effective. But I want to empower the person to understand that they don't need them. There is a bit of again, we're drifting into the crutch territory, that they have these skills. I usually do offer them when we want to ensure that there's some behavioral experiments that they're doing and that they're going well. So there's a clear purpose even to those booster check-ins. You see what I mean? Because again, you risk some drift.
So do these sit outside of the sessions? At what juncture in that journey is that would
is when you've concluded and you're doing a little bit of the relapse prevention. Depending on the case, this might be useful or might not be useful. Again, it's something that I encourage anybody that I supervise to discuss with me as to what the role of those is, whether we are inadvertently creating a little bit of dependence and negating their own, what they've learned and their growth by saying, no, you still need me a little bit. It depends on how you frame them. So you have to be really careful, and they have to be very goal oriented. So that can be okay. But you do have this deliberate tapering, and may or may not include those check-ins when you're doing relapse prevention towards the end. But so if you're dodging this end game, if you're not talking about it, if you're not like clearly signposting and following the milestones towards therapy needs to stop, you will entrench reliance. And again, your client is not to blame. They feel like they need you, and it's your job to make it very clear that no, that they won't need you, and they will be empowered to do this themselves. They have like an internal version of you that we'll talk about that later. That kind of is all they will need. They learn the skills, yeah. And again, they didn't learn the skills from me. They learned the skills through practice. Similar to learning how to play the piano. I don't learn to play the piano for you. You have to kind of sit there and play the piano to actually eventually learn. So who's the one doing most of the work when you're learning the piano? I can give you some pointers. I know how most people do it. I know what situations look like, but you need to play the thing if you're going to get there.
Yeah.
So this was about the modalities, the therapy modalities. I think we had a discussion about that earlier. But yeah, so what are the models that we have good evidence for that utilize this mode that I'm talking about? Yeah. So this one is like the clearest example. I think most people are familiar with this, is the exposure therapy. So you start with a fear ladder. So it might be about, the simplest example might be spirophobia, where you're trying to construct a ladder about exposure to your fear for whatever reason. And you can do that in 4 hours. I've done it many times in just 4 hours, completely cure somebody for simple phobia. Some of the phobias some of the presentations are more complex, like for example, agoraphobia, where you fear going into crowded spaces for various reasons. You fear not being able to escape, or losing control, or losing your mind. That's kind of the underlying fear in those situations. But yeah, so that's a little bit more complex. But again, it works in the same way. It's this exposure way of doing it. And again, there's some cases in which you would not even intuitively would predict it, like this RCT, this randomized control trial, this clinical trial, this study that I'm quoting down here. for intermittent explosive disorder. So this is a complex condition where people lose their temper, and it results in very negative outcomes for them and for everybody else. But when you have these goals and you actually do challenge, and a 12-session well-structured CBT cuts over aggression, even in very, very difficult cases, this very structured with exposure to the trigger. The trigger is what? The trigger is the thing that annoys you. So you need a very brave therapist to explore this and to construct that treatment path, but it's very effective in this kind of case. Not for everything, but it can be very effective. We have another example here with behavioral activation for depression, which is to actually do the thing. So one of the key things in depression is that you're completely demotivated, not only demotivated because your energy feels very low, everything is tiring, your mood is low, obviously, but also you don't enjoy things. So this component of depression is called anhedonia. It's a key component of depression. And basically the activities that you used to like doing, you're no longer enjoying them. So why would you do them? So what we know is that if we do this, if we actually get people to do the things, act as if, right? They do develop the enjoyment. It's extremely hard to get somebody to do this because they're completely motivated. So it's about conjuring up the motivation from nowhere. So this is why that relationship between the therapist and the client is very important, because you need to believe that we're going to get something, even though this is going to be extremely effortful. You're very tired, and I'm telling you that you're going to get your energy back if you do things. What? Doesn't make any sense. So acting first, the mood will follow, is true. So if you do this in a structured way, and if you get your client to do it, they have to work really hard. They won't like it, but we'll get there. And again, every analysis that we do of this type of therapy, when it's well implemented, results in recovery. And well-structured, clear goals.
I'm just thinking of a parallel. I'm going to correct me if I'm going off course here, but maybe why exercise is such an effective thing, because you're acting, you're asking someone to move, and maybe that act of exercising can actually be a catalyst to other changes. Even though I recognize, if someone's severely depressed, getting them to exercise, whatever that means,
yes.
even walking, going around the block,
walking,
can be a helpful
definitely
thing.
And actually, I mean, there's good evidence that exercise by itself is I'm talking about behavioral activation is other activities as well, like being social, which is something that people with depression find really hard. So that's why you construct those, how we're going to do this, and have clear goals, and we're going to do this, we're going to sort of go to visit a friend or something, we're going to do this. No, but exercise in itself is a form of treatment in moderate, mild to moderate depression. But again, it's hard. It's about believing that, I feel awful, how is exercise going to make me feel better? Quite a hard sell. But it's that if you do it structured, you have the goals, you can look at it and succeed. So pain, another very hard one to treat, and this is for acceptance and commitment therapy, hard sell. Because one of the first things that you do in acceptance and commitment therapy is that we need to accept that the pain is there, and the pain is awful. And the first hard task is how do we practice this ability to accept? And again, it's not easy. It's not about having a nice chat. It's about actually ultimately practicing a skill that enables you to accept the fact that the pain is there. And then is the commitment part of the therapy that is also very important. Again, structure, clear goals. We're looking at this, and there's some activation when you're treating pain as well. So we know that chronic pain gets better if you actually move, even when it's painful. So very hard sell. Again, constructing those steps and going through them. Very, very big effort, but it results in a reduction in pain intensity. In some cases, the pain never quite goes away, but it stops being an impediment, and your quality of life improves dramatically. That's why it's worth doing.
Yeah.
Structural therapy, clear goals.
So I believe, and again, correct me if this is the wrong assumption, that this can involve elements of mindfulness and
It
practices and things
does.
like that, which I was sharing my own experience of kind of the challenge of both committing, to use the C in there.
Yeah, which is difficult. I mean, it sounds simple, right?
Yeah. But like many of these things, this isn't a quick fix. This is something
No.
you've got to apply yourself to, and be prepared to have those bumps where you do fall off and
Yeah.
come back to it. But
And that is where the therapist has a clear role, which is to keep you motivated to continue on the journey. So it's not that I'm the magic. It's just that you're a little bit accountable to me. We have that relationship where you're accountable to me. I am interested in your progress, and I am going to check in on your progress. That's my role. But the person that is doing the thing and is learning and is becoming, getting better, recovering, is you. And it's not my effort that has done it, it's yours. That's kind of the important thing to establish. Yeah. So homework. So this is CBT, but it applies to other things. Yeah. Homework clearly linked to improvement and long-term stability in those goals. Yeah, nobody likes homework, but it's important. The good thing, the important thing that I would say about homework is that it's a two-way street. Is that the person needs to do the homework, but the therapist needs to be committed to review it, discuss it, and be interested in it. Because sometimes it might happen that you do your homework, you actually do your worksheet, whatever it is, and it doesn't seem to be discussed ever again. And that doesn't help. The homework is very important. So that's why it's a two-way street. And also sometimes the therapist has to make a commitment to do certain things, like provide the workbook, like provide the structure, like help with the formulation of something. Sometimes it's even about in your discussion there's something that you want to learn more about as the client, and the therapist is committed to bring that knowledge to you in whatever form. Is it a book? Is it an article? Is whatever. So there's homework both ways is what I'm trying to say. Yeah, but very important and actually linked with improvements and recovery.
So the homework needs marking, is what we're saying here.
Yes, yeah. I mean, not marking in that sense, but it needs to be appreciated.
Yeah,
What I'm saying. Yeah. And needs to be brought into context, because without context, is a bit useless. Yeah.
Okay.
Yeah. So yeah, so if you're a client, what are you looking for? What do you should understand before embarking in therapy? That you want your therapist to provide written, measurable goals, as silly as that sounds. You want to have a way to review your progress from the not how are you feeling this week. I'm okay. I'm not okay. That the problem with that is that sometimes you don't know where you really are. So if you decided on a way to measure this, even if you feel not great, because maybe the session itself was challenging, you can track your progress and you can see where you are versus where you were. Sometimes people lose sight of it. I feel terrible, but if you're measuring things, you know that you're not feeling as terrible as you were like 2 weeks ago or whatever it was. That's why it's important, and it actually reinforces that belief that you can do this and that you are making progress, and there's and it is you that is doing this. Yeah. So expect weekly homework, expect to do it, and expect your therapist to actually take an interest in and use it. And discharge the graduation. So you want to get there, and you don't want to need therapy ever again. That's kind of the goal, hopefully. So you need to sort of. It's not abandonment. It's not about I thought they were my friend. No, there's somebody that's helping you acquire a skill. Once you've acquired the skill, once you've acquired the resilience, once you've acquired the ability, that you now empowered to do this. It's not abandonment. You've graduated. Yeah. So therapists, you need to challenge avoidance. Why is that? So challenging avoidance is hard as a therapist, because the client that you're working with doesn't want to do the thing that is hard to do, like the homework or going through the next step of the exposure ladder. So you need to sort of reflect on that. It's not that you're forcing them to do anything, but you need to sort of bring their attention to the fact that there's some avoidance there, so that they understand what's happening, and how do we overcome the avoidance is kind of the question, right? So, and also supervising that counter transfer is, if I am pushing somebody to do something that they find hard, how do I feel about it? And am I myself not doing it because I don't like to do it, or don't feel like doing it? And as an organization, time limited, with clear goals and demand outcomes is what I would say. Recovery rates, not uptake, not usage. Usage may be useless, yeah, without good outcomes.
Makes sense.
Yeah. Last one. Hear the therapist voice in your head, the questions, act on them unaided. You've internalized the model. That's it. You succeeded. Well done. Fantastic. There we are. You don't need me or somebody like me anymore. So yeah. So we need to quality over quantity. More therapy, as we said at the beginning, not always a better thing. Also therapy when it's needed, not in every case. Again, not the person. The person needs to seek help. More on the therapist to do the right thing. Yeah. Guard against incentives. Again, you as a user, as a client, and also you as a therapist need to sort of be aware of the incentives, and be mindful of them. And those are the kinds of things that you discuss in supervision, and those are the kinds of things that you think about when you're a client. Am I getting anywhere with this, or is just a nice cozy thing to do? You need to make an effort. So you expect to work hard. It's not a magic wand. It's not having a nice chat. It is the thing that helps you progress. Is not the thing that happens in the session. Is everything that you're doing between sessions. And just remember that reviews can mislead. Very important. How those are obtained and when is important. Yeah.
We've had we've had some really nice comments. So first and foremost, thank you for those. I'm sure the intelligent side has come from Andreas, but we'll take it anyway. So there's also we've had a Q&A, but I'm not sure whether it's one that the participant wants to sort of address publicly, or it's sort of a.
I mean, if we could send them a reply, I'm sure.
Yeah.
If you help us with that, we can send them a reply privately.
Yeah. We have a few minutes left as well. So if there's any questions that you do want to put in either the chat or the Q&A, then we can do this. But I think we've tried to approach this from a slightly different perspective, and it seems to be hitting the right notes with people. But yeah, if there are any additional questions that you have for yourself, then feel free to put them in the chat. Let's have a look there. I'm just having a quick look.
Private reply. Yeah, we'll do that.
Yeah, definitely. Yeah, we'll do that. But yeah, I don't think we've got any others, so we might close off a little bit earlier.
Might give 5 minutes back to people.
Yeah, maybe people can get some lunch. But yeah, no, thank you for joining, everyone. Keep registering and joining these sessions. It's great to have you on here. And
I'm really grateful for those comments. You're all very kind. Thank you.
Yeah, no, it's great to see. So yeah, have a good day, and hopefully we will see you all soon. All right. Thank you.
Thank you.